It's 6 o'clock Central, and I want to welcome our colleagues and friends of the Phoenix campus, of the Creighton Phoenix campus. And thank you, Dr. Seaman, for helping us arrange. It's a pleasure and an honor to have you here today with us, Dr. Terhune. We'll start with a reflection given to us by Dr. Marcus Balters, the Vice Chair of Surgery for Education, Professor of Surgery, and former Program Director.
So, this might.
Dr. Balters.
Yes. Hopefully this will be a little inspirational for some people. This is from Michelangelo. The greater danger for most of us lies not in setting our aim too high and falling short, but in setting our aim too low and achieving our mark.
Thank you. It is my distinct honor to introduce Dr. Terhune today for a fireside chat, which will be co-moderated by Dr. Neil Patel and Dr. Kyle Castling. Dr. Patel, our residency program director, and Dr. Kyle Castling is an excellent minimally invasive bariatric surgeon trained by Dr. Terhune here with us as well, and we'll be co-moderating the fireside chat. And so I'm thankful and grateful for both of you to preparing it and put together the questions as well. And I want to thank also Joanne, Lena, and Colin from the CME in our office as well for helping us put together this event. Dr. Terhune joined the Vanderbilt faculty in 2011 and is a professor of surgery and anesthesiology. She's currently the Associate Dean for Graduate Medical Education for the Vanderbilt School of Medicine. She also serves as the Senior Vice President for Educational Affairs and the ACGME NRMP Designated Institutional Official, otherwise known as the DIO for Vanderbilt University. Her clinical surgery practice focuses on acute care surgery, and she also serves as Associate Chief of Staff at the Vanderbilt University Hospital. Dr. Terhune completed her residency in general surgery and fellowship in critical care at Vanderbilt. She served as a program director of the general surgery residency from 2014 to 2019, where you trained some of our former Georgetown residents, including David Zhao as well. So I've been following that track as well. And then you became the DIO for the GME program afterwards, that consists from over 150 residency and fellowship, over 100 of which are ACGME accredited, and over 1,200 trainees. She also serves as the Chief of General Surgery at the VA Medical Center between 2016 to 2019. Dr. Terhune is a national leader in GME, giving lectures throughout the country. She's the past president of the Association of Program Directors in Surgery, a founding officer of the National Association of DIO, a current director on the board of the ACGME, which is a huge honor and well-deserved. We were talking, there were about 5 or 6 surgeons on ACGME. And as of you knew, I'm very partial to see surgeons in leadership position, as that will impact meaningful change. And she consulted with GME programs in the past on their policies and practices. Dr. Terhune has received several distinguished teaching awards at the local level and the national level, including the inaugural David Leach Award from the ACGME, the Philip Wilson Outstanding Teacher Award from the Association of Surgical Education. Dr. Terhune received her AB degree in molecular biology from Princeton, her medical degree from University of Pennsylvania School of Medicine, and Master's of Business Administration from the Owen School of Management at Vanderbilt University. We're incredibly honored and privileged to have Dr. Terhune today. I'm going to hand it over to both Dr. Patel and Dr. Castling to moderate the fireside chat.
Wherever, I was like, so, yeah, we're going to go. Yeah. We're going to give you a separate. Oh, yes. Do you want to go first? And I understand we have people trying.
Zoom land.
There's Zoom land folks who hopefully can hear us okay. I'm going to go first. Okay, so we're going to start off with an easy one, which is what drew you to a career in surgical and medical education.
Okay. And I think I tried to meet as many people as I could to know what groups we have people from, but what drew me, so I kind of fell into it. And I think most people who are advancing their career realize you mostly fall into things. We think that we're actually going to go, and I didn't know what a DIO was, right? And I've been that one for 6 years, but none of you knew what a DIO was either. It's not like you wake up and say, I want to be a DIO. But education is something. My mom was a public school teacher in Arkansas. My dad probably should have been a professional educator, but education was definitely what it was. And he actually taught, I say he was a professional educator. He taught business at a small college in our town. That's not what he did for his entire career, but he did that for a period of time. And education and coaching was something that was very important. And I think it was really important. I grew up in a small town in Arkansas, and both of my parents were first generation college students. And I think that they really saw education as something to propel the next generation forward. And so books, things, just very important. But as a result, and in that small town in Arkansas, I'll talk about this a little bit tomorrow in Grand Rounds, whoever's there, but in this town of 10,000, there was this small Montessori school. And my mom, who was an educator, was very interested in this. And so she put me in this school. And that resonated with me so much so that became a part of really what I did. My first term paper in high school was about the Montessori method. And then I was very influenced by a basketball coach who was very intent on teaching skills and also thinking about strategy. And so I had all of these really wonderful people around me who were teaching me and coaching me. And then that just became a part of what I was doing. But I was never planning on being in education, and went to medical school or I went to college, and I was a molecular biology major. And then in the last year of college, it became time to apply for medical school. And I simply did not have the money to apply. I did not have a credit card. And if you don't have money, it's very hard to get a credit card. And those two things, I had to get a job. And that was just kind of what you did. And I had 3, and that sounds, I was coming out of Princeton with a molecular biology degree, but I could not go to medical school at that point. And so I had a choice of working for a healthcare consulting firm in Washington, D.C., working for the lab that I had been in previously in undergrad, or teaching and coaching. And had I known any doctors, the only doctor I had been exposed to was my orthopedic surgeon who operated on me, who told me not to go into medicine. And so had I had, and there's no medical school there, so it's not like I was really exposed even at that point to doctors. Had anyone really mentored me, they would have told me to take either of those first 2 things, right? And that's maybe not what I would say to anyone now with my experience with this, but I didn't. I was a college student. I had put away basketball because I was afraid that I wouldn't be able to make the grade. I didn't have any AP classes or anything like that going into Princeton. I felt like I was very behind everybody. I was not your typical student there. And so I had stopped doing all the things that were important to me. And I really wanted to coach basketball again. And so based on that, I picked the teaching job and then taught for 3 years, and then went to medical school, and then went right back into I want to be a physician scientist, do all of this. And then I arrived at residency at Vanderbilt. And it was in my 3rd year when I was trying to pick a basic science lab to go out to pursue this career that the program director said, have you ever considered doing what I'm doing? And I thought, no, I really haven't. But if I really think about it, all the things that I love and getting to combine surgery with education, that really kind of makes sense. And so I talked to one of my co-residents who said, that's absolutely what you should do. And so then I just pivoted, and at that point became interested in surgical education. So that's really the story of going. So it was, and DIO, again, this was not ever on the radar, but it just happened that at that point when I was program director, there were some things that I really wanted to do from a creative standpoint, and I wasn't able to do them in the position when I was. And I was planning, at that point, I thought, well, I'll just be a program director until I retire. I really like surgery. I really like teaching. This is perfect. And then things happen around you. Leadership changes, vision changes, and the DIO position came up. I was also looking at, and Kyle may not know this, but I was also looking at other positions that would have been program director positions in other places, and a vice chair for education for strategy at another place, trying to stay in the surgery side. And I was caring for my parents, which is why I went back to Vanderbilt, was to be a day's drive away from home with aging parents. And my father was in the VA system. So the best place for me was to stay in Nashville. The DIO position came up. And so I kind of pivoted into the DIO position and ended up sort of furthering education on that side. So it's a long long and meandering road that I'm not really sure where it's going even now.
And we should say that anyone is welcome to, ask their own questions as we're going through the list that we have prepared, but we want it to be meaningful for you guys to participate.
Yeah,
too.
please. I like interrupters.
I think we can probably skip number 2 because it was kind of about outside experiences that led you to where you are. So that was perfectly captured. Can you speak a little bit to kind of your transition from being a faculty member, being a program director to now being DIO, and about how your philosophy of leading and teaching has changed?
Sure. And I think this is probably the philosophy, my philosophy of education completely changed. So whereas it was very much the granular educational, how do you teach, how do you coach, how do you get people to that stage? Sometime during residency, I think it was near the end of residency, I started realizing that, and I had been very active during residency in setting up our simulation curriculum and doing a lot of things that were really program director jobs, but were, and I'm not saying he wasn't doing, it's just that that wasn't the focus of our program director. And so there was a group of residents that came through and we just totally revamped everything. And in doing that, I realized that I was trying to go and talk to hospital administrators about why they needed to invest in education, and I didn't have the language to do that. And then when I thought about what GME was, it's really taking unskilled workers and turning them into very skilled workers and professionally developing them to become leaders and division directors and chairs and things like that. And I thought to myself, that's actually what businesses do. And so when the choice was to get a master's of education, which Kyla got, and which I would totally support in all these situations, I felt like I'd had enough curricular development at that point. And so decided to get an MBA to really understand what professional development looked like in industries that were similar to ours. We are trying to develop people, and we have a product, and that's healthcare. And there are other very much human capital organizations, and I wanted to learn from them. So that was the purpose of getting the MBA. So my philosophy for education and about education completely changed to more of structural and systemic, and how do I facilitate that? But still, which we'll talk about tomorrow in the grand rounds, is really still honing in on what are the granular parts of being a good teacher, and how do you create systems then that allow everybody else to do that in that system. And so that has completely changed. So now I would say I feel like I have this really big view of education, which is I really like to, and Kyle will remember this from when he was a junior resident, I really like to hone in on technique and handling of the tissue and preoperative planning and thinking and teaching and thinking about the granular aspects of that. But in the DIO role now, we have 177 programs, 109 ACGME programs, 1,200 residents and fellows. And it is a little bit more like a business. And I'm not saying that it's not the dirty parts of a business, which is not about the money, but the really good parts of a business, which is about professional development, developing people. So what I thought I would miss as a program director, and I did miss as a program director. So for example, Kyle was a direct mentee, but it was at the time that I was transitioning into DIO, and my parents were not doing well those years. So they passed away in 2021. So I didn't get to have as much direct resident work, but it turns out that I get to mentor all these amazing program directors, who many of them were our former residents, and have come with really interesting ideas and really interesting thoughts. And so it just ended up being, I feel like, a program director of program directors, and I still get to, I don't get a lot of the direct credit for which I don't need, but like I get to watch everyone else doing it, which is fun. But it has been a transition. And as you know, in the DIO position, I spend a lot of time with legal. I spend a lot of time with compliance. I spend, I get the highs of the high. I don't get the highs of the highs, actually, now that I think about it. But I definitely get the lows of the lows. But yeah, I don't get any credit for all the people who are really succeeding. It's just like, but I definitely deal with, and when I say the lows and lows, I get to deal with some really interesting issues that are really in the world of GME. You get to intervene at a time when people really need you to intervene and sort of support. And so when I say the lows of the lows, those are also some amazing saves, and you get to watch development and watch recovery. And so that's been it. And then by operating, this is important for all the surgeons, is I had to really say, because all of a sudden my outcomes are different. I would also say my transition to being a DIO was 2019. And so in 2019, in July, world was great. And I was sitting in an emergency operations meeting And I realized that, and from a surgeon standpoint, I think mass casualty is the biggest risk that we're going to have. And I realized that we had no system to alert and create a system of reporting or for any mass casualty system. And so I sat down with a guy named John Morris, who is a surgeon and ran our emergency operations. And this is 2019, October. And he said, you really need to think not just about mass casualty. He said, but you need to think about structural disasters and you need to think about pandemics. And I said, wow, that would look completely different. And then we start hearing about this thing called COVID. I presented our plan in December of what we would do. And it included what we would do if there was a pandemic, what we would include if there's a structural disaster, what we would do if there was a mass casualty. And so lo and behold, in March, those of you who are not in Nashville, you'll remember this, but in March 2020, first we had a tornado. And so we actually tested our system a little bit. And then 2 weeks later, we had our first case of COVID. And then, so all of that went into play. So that was a big, and this is the part about the surgeon, my outcomes and what an institution needed me were completely different from what it was before. Nobody cared whether I took another gallbladder out again. And so I went into the ICU with the residents. It really became about outcomes with what do we do in these situations. And then I had to say, how do I define myself and what do I need to still be a surgeon, because that's my identity. And so I said, if I need to be able to take out the gallbladder when it comes in, I need to be able to take the appendix when it comes in, I need to be able to do that. And so over time, almost had a reintroduction and then came back over to Vanderbilt, just very determined to make sure that that was still a part of what I was doing, right? And so now I'm on EGS, which I wasn't when you were there, but I was just like, I need to have something. So does that answer any of those questions? It's a lot. There's so many different directions you can go with these questions. And I don't really get a lot of people who are asking me like things about me like this. So this is
Yeah, I mean, I think that's fascinating. I'll go a little bit off our list here because I'm curious, I think you alluded to this already, but as you transition from being a faculty member to a program director to a DO, the scope of what you're doing really seems to change. And I'm curious, what kind of surprises or challenges you encounter in that process.
Gosh, yeah. There have been, surprises and challenges have happened really along the way. And I could probably come up with a lot. I think where my mind is going when you ask that is, what do you do to try to preempt and avoid surprises and challenges? And I think part of it, if I think of the surprises, I'll tell you one, and you'll recognize this as well. Surprise is program director. So, and I use this when I'm talking to our program directors now. When you become program director, you're thought of as an excellent clinician, an excellent mentor. That's why you're appointed program director. And you usually have some mentees who you've been very close to, and then all of a sudden as program director, you're responsible for everybody. And you're responsible for everybody equally. And so whereas a faculty member can mentor kind of who they want to mentor, a program director really has to put just as much effort into the person where it is a positive interaction as they do to the person where it's a negative interaction. And not that was a surprise, but I guess it was in some ways, but it was a realization, and it changes the scope of what you do, because you also have to be very careful to show that you're not playing favorites, that you really are trying to be there for everyone. And I think part of the surprise was really trying to work at that and say, when am I doing that well and when am I not doing that well? And there were certainly some times when I feel like I did not do that as well. And a big surprise was when I was going through business school, which was when I was program director, I did one of these 360 evals. How many of you in the room have done these 360 evals? They can be really painful. And so I decided that I would give it to, my bosses, my coworkers, and then for the direct reports to me, I gave it to the 4th and 5th year residents. And I learned some things about myself that I really did not want to know, but they were really valuable, and they affected the way I communicated. And it maybe helped and propelled me along to be a little bit more of a leader, or things that I was doing that I thought were very helpful were clearly not very helpful. And having the ability for them to say that was really important. So I would say those were surprises, and trying to be comfortable with people being very critical of you. I would say early on and through the transition, you want people to always call you and tell you you're doing a great job. And I've learned that just does not, just does not happen. It's very rare. But I do get a lot of people who call and tell me how I can do things differently and how I could do them. And trying to learn and practice a response to that has been a shift and a change. So I think it's just being encountering each one of those things. And as far as surprises, when you have 1,200 residents, anytime a program director calls me, it is going to be another surprise. Like hands down, it is going to be something I have not, 2 things this week, I can tell you, I have never encountered before. And both things will often require calls from me to other groups. So there have been plenty of surprises with that. And I think the first time as a program director that you have a resident who is really struggling to the degree that you're worried that they're not going to be able to complete a program or something like that, I think those are some of the surprises that you run into that you just don't see from maybe the other side. So, and then as DIO, there've been just continued surprises.
That's great. I'm curious, with regard to feedback, what's your advice for taking feedback that is uncomfortable or critical? I mean, I think we all, I'll speak for myself. I mean, I think that's always a struggle, especially like when it's true.
Well, that's human, right? Like it never feels like, I mean, I think of the simplest example I use is when you have something in your teeth, right? You have something in your teeth, you want someone to tell you have something in your teeth, but it doesn't feel good when they tell you because all of a sudden you're just like, oh, cringe. Like that's like they were looking at me and I had something in my tooth and how long were they looking at me? And that must've been very awkward because I hate looking at someone when they have something in their teeth and everyone's like, do I have something? And I'll be honest with you, I went to the bathroom just to check before I came here, but so feedback never feels good. And you're not ever trying to get it to feel good. And I tell people shame is actually okay and propels us along. Shaming is not good, but feedback, the same thing. It's never going to feel good. What you want to do is you want to practice kind of that quick dissipation of, okay, now I'm going to move into this feels fine. Actually, I gave a talk earlier this week, and this is probably a great example. And it was at another institution. I gave a talk. I went through, it was one of my favorite talks. And I felt like I had it down. And a medical student came up to me afterwards and said, I have some feedback for you. And I'm going to be honest, it didn't feel good when she said that immediately because I was like, what? I just gave a great talk. This is the one you're supposed to come up and tell me how awesome it was and all this. By the way, I'm inviting you to give me any feedback you want to tomorrow. And the feedback was really good feedback. And what it was is she said, when I looked at your slides, I have worked with a lot of people with different abilities and different visual abilities. And when I look at your slides, some of the print, I couldn't see it. And if you just take it and make a box where the print is, and you'll see tomorrow, and you'll see it because I haven't changed these slides since then, right? And I thought to myself, can I change them before I go to Creighton? But she said, if you put them in a box, you'll be able to see the print easier, and that would make a lot of difference. And what she did was she delivered excellent feedback. Did it feel good? No. Am I better about taking it? And what it does is you just kind of have to let it wash over you, take it in, practice saying thank you, and then reflect on it. And my reflection on it is, that's some pretty low-hanging fruit. It was completely objective. There's no emotion associated with it. And she genuinely wanted my slides to be better. So if someone genuinely wants me to be better, and yet, here I am talking about feedback, but so it takes practice and you just have to say, wow, does that make it better? And it's the same thing when residents call or faculty call or someone calls to complain to me about something. One thing I practice doing just to put myself in the right mind frame is if someone calls me, the first thing I say, no matter what they're calling about, is how can I help? Because I found it does 2 things. One, it puts me in that frame of mind. I'm automatically saying what I'm trying to do is I'm trying to help. It also completely disarms them. If someone is really angry and they're calling you to say, how can I help? And that's a time when they're giving me feedback. They're giving me feedback about something that is clearly my fault. Then if I say, how can I help? Then they stop and they're like, whoa, they're expecting me to probably be adversarial with them, to be defensive, like you're expecting someone to be defensive, and that disarms them as well. So I think if in receiving feedback, how do I like to receive feedback is someone asked me that, they said, how do you like to receive feedback? And I thought, well, I like to receive it as if I feel like the person respects me. And so I think if we can give feedback as if we respect the person, and that medical student who came down, was completely respectful. And I felt like it was, so that was, but does it ever feel good? No. And so I think you just have to practice over and over again, that feeling, letting it wash over you, and then reflecting, can I employ that? Was that good feedback? And sometimes feedback is not good. Sometimes feedback is not accurate. And we'll talk about that a little bit tomorrow. And what do you do with that? That's the other part.
I think, your medical student aside who appears to have mastered feedback, I think one question is, two questions. So one, how do you get people to give you feedback that's effective or useful? And especially if there's some positional power there, if you're a DIO or you're a program director, or you're a chair of surgery, how do you get people to actually tell you things you need to hear?
That's a great question. And it's going to be all the simple things that we feel like we probably should do. It's going to be a lot of the simple answers, but that are really hard to do. One is just constantly making it open and showing examples. Like, first of all, if you're meeting someone for the first time, or you're meeting, let's say you have a group that you're working with for the first time, it is just being transparent. I would like your feedback, or I want to hear things. I'm trying to put this maybe into a surgical perspective in a minute, but let's just think you're working with a group, is opening that communication. The second is, you are not going to get it immediately, but later, as people start giving you feedback and people start witnessing what you do with it and how you handle it, then people will be much more willing to give you feedback and feel like they can call you. And they're not always going to get, an answer from you that they want, but they'll be able to do that. If I'm thinking about in an actual surgical case, how do you kind of manage up with that, is just showing that you're receptive to it from the beginning. And we'll talk tomorrow about the educational timeout, which I try to employ all the time. I don't always, but when I do, it just opens the communication, because you are almost preempting someone to say, okay, what do you want to work on? And if someone tells you what they want to work on, then that is what they're going to get feedback on. And they're already expecting it. They're prepared for it. And they know that you're going to give them feedback on it. And they're already prepared for the fact that it's not going to be, hey, great job. It's going to be, if you were telling me you want to work on that, we're going to talk about what the next step is to get better at that. And so then that's another great way to do it, is to kind of say ahead of time, we're going to do feedback at this point, and so I'm expecting it and wanting it. So people talk about the sandwich feedback, and I don't necessarily calculate that out, because I think that the sandwich, the bread part, which is supposed to be the positive part, I think can be dealt with just with respect. And I think about you can give respect. And I apologize to anyone who comes tomorrow and I tell the same stories, but, I have had a situation where I have sent people out of the operating room because we're looking at anatomy and it's very clear that they don't remember it. They probably learned it at some point, but don't remember it. What's the best learning for that person? To keep struggling and to keep on pimping them and not to get anywhere and to try to teach them in that manner? Or sometimes I will just say, you know what? You're not needed at this moment. Go out, look at this, refresh yourself, and come back in. And then when they come back in, sometimes I'll have the scrub nurse hand them the pen. They're going to draw it out, and then we're going to commence and we're going to go on. So when someone realizes that you're trying to give them the best learning possible and you do it with respect, that's a way you can do. Then the feedback there was, you weren't really prepared as I would like for you to be for this, but I also think that you can't always, it's a read my mind as to what the preparation is you're going to come into a case with. So
Kind of moving to the opposite end. So we talked about kind of managing up. How would you, or what advice would you give to trainees or people who are more junior, who are seeking feedback, want feedback? They're just not feeling like they're getting the information that's helpful to them.
Yep. Again, it's going to be opening the communication. And sometimes that is feedback in itself, right? It's a little bit metacognitive, but the feedback to the person who's supposed to be giving the feedback, right? I'm not getting the feedback. It can be just as simple as asking very specific questions. Again, I would say preemptive. If you're the junior and if no one asks you how many of these you've done or what you want to work on, just saying, hey, I'd really like to work on this today. Or I did this case with so-and-so last week. I'd really like to work on this again today. Or they gave me this feedback. That's a great one, is they gave me this feedback. I'd like to work on this today and you tell me how I'm doing. And you're just, again, setting the stage for a preemptive part. Let's say that you haven't done that though. And at the very end of the case, you really want some feedback. I'd almost make up, I was really focused on this part of the case. Can you tell me how I did? Because it delivers on a plate something very succinct. If you just say, how did I do? I even have trouble with coming up with something other than you did great, right? But it's much easier if you say, this is the part I'm really working on. And can you give me some feedback on how I did, retracting today, or how I did dissecting out the critical view today? Or can you give me feedback on how I used, a specific instrument, the suction or the hook cautery? I mean, it can be really that specific, because we as surgeons, we get very specific about how you do every little thing, right? So if you give a little thing and say, how did I do on this? We're going to be pretty critical of how you did on that. You're going to say, well, I didn't like, the way when you use the hook cautery and you had the electrocautery on, that your direction was over towards the liver and it wasn't back towards the trocar or something like that. So you can get very specific.
Specificity is always great.
Yes. Yes. Component of good feedback.
If you were to give anyone in the audience advice on if they wanted to improve their skills at giving feedback or even receiving feedback, any particular resources that you have found helpful or directions to point people in?
I think figure out some way to make it succinct communication. So there's the BID method, which is in the literature. The one that I really like, which we'll talk about tomorrow, was developed at Vanderbilt as educational timeout, which is just, what are you working on? And so being very specific is the best way in creating it. And then the other part, which we'll talk a little bit about tomorrow, is trying to eliminate labels from what you say. So eliminating this was great, you're doing great. And those are not necessarily wrong, but trying to get very specific. And especially if you have a negative label, like you were, very inefficient, taking that and being as specific as you can and really thinking to yourself, why did I think this person is inefficient? Why did I think this person, is not at their peer level? What is it? What is one thing that they can work on to move, and being very specific, because residency is years. And so you really just want little bits of it each time, and kind of relying on your other partners to give feedback in different areas.
And then how about for things that are like less tangible, oh, you moved an instrument in this way, you did this part of this case this way. How about for things that are a little bit more interprofessional, interpersonal? How do you tackle those types of
I think you
problems?
can still be specific in those too. This was awkward when you said that to this patient. Like when you walked into the room and did not make eye contact, the first thing I would work on is making eye contact with the person. Or this consent, when you filled out this form, here is where it was not done well. So being very specific in those as well. There's some things that are hard to get feedback on. So we're having feedback on feedback. There's some things that are hard to get feedback on, and those are hard to give and get. And that is when there's a lack of insight. Okay. And the other part is that you can't start with big feedback if you haven't started with the little things too. So those are hard. You can't really give feedback and tell someone you need more insight. So sometimes, and I'm sure you've encountered this as program director, but sometimes you have to tackle really big issues before you can actually tackle those things with specificity. And sometimes there are things that we can't deal with as program directors or as faculty members, and you really have to get someone in the right frame of mind to move forward.
So I've always been taught that feedback should be timely. How do you deal with situations where you struggle to deliver the feedback in a timely manner? Because, I think maybe you're rounding, you're seeing a patient, you're running all over the place, and you don't want to give this feedback in front of an audience. And it's the end of the day, and now you've forgotten what you wanted to give feedback for. The resident has gone off shift. How do you manage that?
Yeah. I mean, it's good to be timely. Sometimes it's not good to be timely if you're emotionally charged, right? Let's say you're really angry, or it was a tough case, or you're struggling. Then I would say do not give it in that moment anyway. So then I would say it's almost just the opposite. You definitely want to wait. But let's say you've waited. Sometimes you have to let it go. And I would say give yourself permission a little bit to say, okay, I really wanted to say that. Or you regroup the next time and say, hey, we didn't get to debrief on that case. And the one thing I would say to attendings, and I feel like I've made this mistake even this year, is that if there's something that really you're thinking did not go well, or there's a complication with the patient, touching base and debriefing the case, and that's not even necessarily, it's almost feedback for the entire team, is really important to do in a timely way. And I sometimes forget that if you don't do that in a timely way, people can really work themselves up emotionally and be upset about things. And so I know that for those situations where things have not gone well, even though you kind of want to put it away and get home for your day, those are the times that you really want to make the time to say, okay, this person's gone for the day. However, this was such a tough case and situation that we really need to debrief this in a respectful way. But those are the times when I would say I would even make the phone call and just say, okay, we got to go through this, even if it's while you're driving home or something. But it's always appropriate to go back and say, let's talk through this case. You're not going to remember things as well. Like there's a reason that, and do you all use Simple or Firefly? Use Simple?
Yeah.
There's a reason it expires in 72 hours. And that's because if you have let it expire, you probably shouldn't be giving the feedback at that point because you're not going to remember the specifics to make it useful feedback. And so it is important to try to do that within a time frame of our own human memory because it's just not useful. Otherwise, it's not useful to the learner, and the person who's giving the feedback is probably not giving as good a feedback as they would. But up until that point, I feel like you can really, up to 3 days, you can still go back and debrief. And if there's been something that's really been emotionally charged, waiting a little bit is a good time anyway. But if it's been something where you're worried that someone's going to be disappointed or a complication, trying to close that loop sooner just to open it up for more conversation is good.
We do have one question on the chat. Is that okay for me to ask that?
Please.
Dr. Terhune, the question is, some of our trainees and learners think that no news is good news. And so they're assuming everything's going really well. How do you differentiate between getting no feedback and the risk that is involved with that of getting no feedback for learners? So kind of the difference between, I think they're asking the difference between getting critical feedback and the risk of no feedback. How do you talk through that with learners and how important the critical feedback is?
Yep. Well, I would say no feedback is always a risk. I mean, all of us have had that situation where the end of rotation evaluation is a surprise to us because we weren't getting the feedback, right? That's not uncommon. We're like, nobody told me this. We are all human, and attendings and we'll talk about this tomorrow too, but like to be liked, right? We like to be respected. We like to be socially. And so avoidance is a very natural response to it's the solution to not wanting to give good feedback. And so I'd say when there is no feedback, it really is incumbent on, I would say it's the attending responsibility to give the feedback. However, that's just not always going to happen. And so for trainees, it is really important to ask for it and to invite it, because 100% of us in this room could be doing something better. So there is not a single one of us who could not find someone who could tell us that we could be doing something better. I mean, I just had a med student criticize my lecture like 3 days ago, and so 100% of us can do that. So if you're not receiving something, it does not mean that you're doing great and doing everything perfectly, because I don't know anyone who's doing anything perfectly. So I think that the charge then becomes the challenge of saying, hey, can you give some feedback? And then to make it easier for the person to give you feedback, don't ask how you are doing. How am I doing is like the worst question you could ask. And that is trying to think to yourself and being proactive about what am I really working on and what do I think I'm struggling on, and use that to get the feedback, because you're also going to learn at a faster rate too. So use that and say, I am really struggling with this. I didn't feel like I did as well as I could have on this case. Could you tell me what you observed and how I could do that better?
I'll admit this question is a little bit selfish just because, this is a problem I deal with, but I think it's applicable to anyone, who is a resident or senior resident where you're managing a team. How do you deal with feedback that's given to you about someone else that you did not directly observe?
You mean like maybe the program director who the faculty member comes to you and says, you got to fix
Just
this?
hypothetically.
You're asking for a friend?
Someone, yeah.
And that is the avoidance of feedback, right? And that's when you're hearing the silence and then actually the program director is having someone talk to you about this person. So there's a lot of ways. There's the program director way, which I think if you've been in any new program director workshop or anything where I've talked about that or any of the other things, and is if someone comes to me with feedback about someone else, the first thing I do is send them an email and say, hey, I heard you said this, this is what I understood in our conversation. Is this accurate? And I also am going to ask, have you spoken with this person? And I really am going to encourage them that I think you would be the best person to speak with them about. And if they're avoiding it, that becomes a whole coaching conversation for that person, right? Of how they can give that feedback. Because if they felt strongly enough to share it with you, and so this is a chance to empower them to actually actually give that feedback. So one, I try not to permit it, but I also try to document it because it's an assessment that I need, as program director, to get a bigger picture of what's going on with an individual. And I can incorporate that into feedback later, but I really want to coach that person to give it. If I know I'm not going to get that, and I'm sure you've had similar situations, next thing I'll do is I'll ask the resident how they think they're doing. Because and I'm assuming this is sort of an attending resident thing. We're going to use that generalization, but this could be resident medical student. This could be senior attending, junior attending, all of these. But with the resident, ask them how they're doing, try to get an idea of self-assessment. And if it's a place that they're struggling where they really need improvement and you're sort of judging from these personalities that you're really not going to get any more teaching out of this individual, sometimes it's referring them to someone else that they can work. I mean, it really depends on what the skill is and what the feedback is that you're hearing. So it ranges from trying to empower this person to actually talk and give the accurate feedback and how to do that to, is there a problem here that we really need to fix? And if we really need to fix it, I need, try to figure out all the ways that we can empower the learner to get there.
I think we assume that the feedback people are being given is, obviously in good faith and genuine, but sometimes I'm sure there are situations where the feedback actually models a bad behavior. And what do you do with that?
Clarify that a little bit more, models of bad behavior.
So maybe there's there's a professional behavior or some, technical thing. I think, maybe that's debatable, but, or something that's just clearly wrong, that would not be accepted. And someone gives that feedback to a trainee and says, this is how you should do it every time. And they internalize that. They're like, my attending told me to do this. And now later they're getting feedback that is the exact opposite. What do you do in that situation?
That never happens, right? It never happens that someone does one thing one way and says that this is the way you should do it, and then someone else does it completely different. There, I'd say we're looking at residency training, right? And we'll just use the generalization of residents working with attendings. Always do it the way the person you were learning from does it right then. That is the only thing, because you, as a learner, I didn't at least, you don't have the perspective on what the best way to do things are. And there are a lot of different ways to do things. And so sometimes feedback is opinion, right? That you should do it this way. Yet it might be that it actually is better off the other way. But just sort of learning and absorbing the feedback from one individual and then filing that away, because sometimes feedback is always not great. And then filing it away and then making some decisions when you see a better method or see a better way of doing things. And then also getting input from people and peers and others who you're working with as to what their experiences are with different people in this. Feedback is not, just because you're an attending does not mean that you are one, and all attendings will feel is that you're perfect at what you do. Does not mean you don't make mistakes. And does not mean that you sometimes are telling someone a way to do something that there might be a better way. And but we also have a lot of people who would never believe that, right? So nobody is perfect at being, nobody's a perfect person in these situations. But I think learning how to file away feedback and then seeing with what frequency you hear the same comments is important too. So you don't have to, not all feedback is accurate.
Thanks again. I have a question from a chair perspective where, we have faculty, and I'm sure you see that in every program, that they're reluctant to give feedback due to concern that the residents will not take the feedback very well, and it will reflect on the actual faculty or on their evaluation. And likewise, the residents may or may not take the feedback, and some want the feedback. So we run into those situations. Now, I'll tell you, on a weekly basis, Dr. Patel gives me feedback. We call it Friday feedback. He considers it feedback. I consider it weekly beatings. So, I'm sure you run into the situation in Vanderbilt and others.
Oh, absolutely.
Thoughts, advice?
You're kind of taking away all my punchlines for tomorrow.
We'll hold off that.
But the truth is that we have a lot of fear in saying anything constructive, right? But that is also maturing as a teacher and people who are junior in this too, is getting a little bit of a thick skin and kind of developing the, you know what? And we'll talk tomorrow about who is the focus here. Is it not, it's not the resident, it's not the attending, it's actually the patient, right? And so if you feel strongly enough that something is being done for the patient, developing a thick enough skin that you really don't, I'm not going to say I don't care. And I'm saying this, I'm feeling like I've got residents over here, correct? People always sit in different spots, but, and you have to develop a point that you really don't care about the emotional response. It's not that you don't want the residents to have a positive emotional response, but if they're going to get angry because you're doing the right thing for the patient, you feel very strongly about wanting them to do the right thing for the patient, then a maturing teacher learns to sort of say, you know what, this might make you angry that I'm saying this, but this is really important. And that being said, some attendings as we're going through never reach that point, right? Because the social acceptance and the desire to be liked is really, really important and almost overrides the ability to give constructive feedback. And that's dangerous. And we'll sort of talk about that. And so the real focus, if you can dissociate the emotion as much as possible and put the focus on the patient. I mean, my very simple explanation that I gave to you earlier was that presentation where the med student gave me feedback. The most important person was not that med student, not me, but it was actually, was I delivering a better presentation? Like, and so sort of if you have a patient and it's really, can you do this operation better? Can you do this skill better? Was there something done that if you continue down that road, it would be dangerous? And it's really about the patient, then starting to put the emotion and say, I really don't care. I think about, I don't know if you remember this, Kyle, but I will often put up the slides of 3 people. You know, maybe you can tell me what these people have in common. David Schaefer, and I'm using their names and they're wonderful. David Schaefer, who just retired, Kelly Wright, and Mike Holzman. Size is the, and heavy size. You're hearing S-I-Z-E. What she really means is S-I-G-H-S. Okay, so she's talking about their persona. And so David Schaefer, who just retired, kidney transplant surgeon, or he's got a few more cases. Liver transplant surgeon is Kelly Wright. And then an MIS guy, Mike Holzman. There are 3, and I love them dearly, and I hope that they respect me for saying this, but they're 3 of the grumpiest people I've ever met. And they will make you feel like you are the worst surgeon in the world when you're operating with them. The number of times that Holzman was frustrated with me as a resident, Kelly Wright, I think, you know, that's silk toxicity, you know, just, I can think of all the times. And then David Schaefer has this side. They are 3 of the best teachers. And what they could do is, in sort of observing them and saying, how can I do this? Is they really treated everybody the same, and it was about the patient. And if you weren't doing what was right for the patient, they were going to tell you it was right for the patient, and they really didn't care whether you got upset about that or not. And that was hard for residents initially because as a junior resident, you were scared to death of them. But what about when you became a senior resident and worked with them? Absolutely adored all of them. And why was that? Teachers. And you improved and you realized that you were improving with them. And so some of that is like maturity of thought, but some attendings don't really get past that. And it's kind of the buddy part, and that becomes, the relationship becomes more important than the patient on the table or things like that. And you know, they're taking everybody out for drinks, and I'm not saying that you shouldn't do that, but like that becomes the feel good part of it becomes more important. And those guys, that was not what it was about. It was about the patient, and you learn so much from them. And so I think really developing a way to give feedback in the way they give it, and you felt respected. Like at the end of it, you felt respected. You didn't feel like you were their favorite person ever, but that's probably the way it should be because that wasn't your role. So that's kind of with that is like developing that ability to say, I care. Now, do you have to do it that way? I think you can be friendlier, but they're all wonderful and friendly people. But you can do it with other styles as well. But I think the key part there was that it was really about the patient for all of them.
You know, so once you've gotten your faculty to all give feedback, you know, sometimes you can see a problem. I think especially, you know, in professional interpersonal skills, but you're not sure how to fix it. You know, lack of insight, I think seems impenetrable, but sometimes you're just not sure what to do. How do you handle that situation?
Well, that's when I say I'm a surgeon, and that is not what I trained in, was teaching people to have insight, right? And there are people who are trained in that. And as a program director, if I'm really seeing that, sometimes I will ask people who are professional at that to work with the residents. And that's when you will get professional coaching. Or If there is a surgeon who I know can particularly relate to this individual, that's when, you know, you can use that. But if it is truly a lack of insight, I will use what is, and I'm sure you have an equivalent here, but our employee assistance program and employee professional coaching, which is really what you want to do is you want to rule out all the things that may be impeding this very intelligent person from progressing. So you want to make sure that there's no, we have uncovered so many things when you look at someone who should be excelling and they're not excelling and they're not responding to feedback and they're very defensive and they're upset and you're thinking, why is this person responding? And you uncover things like they're going through a divorce, they're having financial hardship, their parents just, one is ill and they can't really get home to care for them. And so having them in a situation, the first thing you want to do is you want to see, is there something that is keeping this very intelligent person from progressing forward and from responding in a way I would expect them to be responding. And then beyond that, they can also help you with, you know, are there other things that are going on, mental health issues, or are they on, we found, you know, sometimes people will be on medications that we didn't know or haven't had medications. I remember one situation of, and just, this is just an example of sometimes you have to think bigger. We had a person who the feedback was junior resident, and the feedback was this person is not following instructions. We are giving a list of things in the morning, they're not following instructions. And finally, I sat down with this person, and it turned out that they had a hearing deficit, and they had arrived in Nashville and had not been able to get, had lost one of their hearing aids and not been able to get to a physician to get the other one adjusted. They weren't following instructions because they didn't hear them. And they were in a power imbalance situation and didn't feel like they could share that because they thought that an intern's job was show up on time, be there, do the work, and they didn't even realize that they weren't actually doing the work. And so through that, you're like, okay, well, we can help with that, and the person ends up doing just fine. So there's sometimes when you give feedback and you really have to say, is there something here that is keeping this person from either hearing or receiving this feedback in that manner? So, but utilizing, there's some situations where I just say, I don't really know what's going on here, but I'd really like for this person to talk with someone and maybe not their program director, because as nice as I think I am, I can remember, you know, sometimes some people working with me, I find out actually I'm kind of intimidating and I didn't realize that. And they may want to talk to someone else about that. So bringing someone else in to say, can this person help? And I would say also as program directors, this is a really simple thing. And Kyle will remember this. I had 2 associate program directors and then a third one, all of whom were very different from me, and purposely so that we could try to capture really everybody in the residency, so that if they didn't feel like they could come to me with something, they had someone else that they could come to, because those things are important even with feedback.
That's great. You know, I think that since I was a resident, like feedback within education has become so much more prominent and so much better and nuanced. You know, Dr. Castling is our EPA champion and doing a great job. You know, and we're always asking the residents and the attendings to do EPAs. What's next? Like, what's the next 3-letter thing we're going to be asking the residents to be doing?
Let's see. Well, the next thing would be, what can we do with those EPAs? Right. And I think that is going to be next. And I think, well, with those EPAs and for the residents too, it will be, now that we have these EPAs and they give us information, how comfortable can we be with either really moving into competency-based education and accelerating to finish early, but also waiting to finish later. And we, you know, people talk about competency-based education. We do that already to a degree, but we don't do it with finishing earlier or partial credentialing. Actually, I think partial credentialing is one that I think could probably happen next. I mean, it doesn't make sense that a chief resident who can put in a central line better than probably, you know, many attendings could not be able to, we're talking from the CMO standpoint, who could not be able to bill for that if they're doing it and the attending's not there. You know, moving into partial credentialing of saying, once you reach competence, can you actually do that? And then we have a real transition to practice. And that may be the next thing that we do with it. Competency-based education right now, we only do on the remedial side, meaning that we only prolong people for the most part here. So I think the next thing will be, can we do that really with an entire spectrum and normalize that so that people are going through and they finish when they're ready. And then the partial credentialing, I think, would be an interesting potential next step too.
How do you square that with the financial implications of, we have 5 years of funding per resident.
Yeah, great question. Well, I would guess that you all are already over your cap here, which was established in 1996. And so every resident that you add, and this is a testament to your commitment to GME, every resident that you add right now is actually, you have to come funding from the institutional side. So that would be an institutional decision. And if you can normalize that, you should have the incentive then to finish earlier as well and to move on. And so it should balance it out so that it actually ends up being on the average of 5. And I think it still will be an average of 5 to finishing.
I wanted to go back to something you had mentioned earlier about when you've sent residents out of the room. So I can remember being sent away from the scrub sink once as a general surgery resident and kicked out of a cardiac case once, and I was devastated. I just wondered, with all the discussion there's been about the changes in the generational learning styles and stuff, like, have you had any problems with that?
So, well, I won't say that I do it frequently, but I will say it's how you do it, right? If you start out by saying, and this is the conversation that I would have and I did have, is I recognize that you don't know this anatomy right now. The best way for you to learn this is not for us to go through it right now. And so this is not a punishment. It is like saying it right out. This is not a punishment. But I want you to go out, look it up, come back in, teach us. And if I'm saying it in that tone of voice, I don't think that anyone would think that that is going to be negative. I would guess if you were kicked out for this, it was probably some yelling, some screaming, some stomping of feet, some you medical student, some, I can't believe you can't do that. Can you wash your hands? Like all the bullying, right?
Yeah, it was very threatening.
A very
It
different.
was,
So
you should leave right now before things get really
That's right.
ugly.
And I can't imagine having a conversation with anyone like that, right? And I don't think, hopefully not, Kyle, that people would ever imagine that I would have a conversation with someone like that.
No, can't picture it.
Yeah. And so if anything, and it's okay for them to feel like, okay, maybe I disappointed Dr. Terhune. That's okay. That's like your parents, like, you let me down, son. It's like, but I still love you. And it's sort of the same thing. So it is totally in how you deliver at and set up that conversation. And I think genuinely that person thought that I wanted them to learn that. And what I cared about was whether they learned that. And when they come back in, the other part is when someone comes back in, you receive them back in and it is I am glad you're back. Tell us what you learned. Yes, that's right. Good. Thank you. Now you got that. Let's show you. Can you see this now? And so this is really important that you be able to see that. So I think it is totally about how you deliver it. And if you can deliver it to someone with respect and show them that I really want you to understand this. Now, there are times that, I'm angry with people, I'm upset or I'm disappointed, but it's never I don't think you can do this. In fact, that would be why I'm angry, because I'm like, I can't believe you've got to be able to do this. So I think that is exactly when people, and it's interesting because whenever I share that story, there's always that shock, because what people do is they remember what they think of as being sent out of an operating room. And I guarantee you, it does not feel that way. It is just and it really, it's competency based. It's saying, hey, come here. But it's all about, I really want that person is attending, they're doing great and they're fine. They're not, I don't think they're emotionally scarred from it.
So as the token, I think I'm the only CMO in here, but also of a hospital that is GME naive. So in our system, my hospital is only 20 years old. And so we are embarking in beginning of residency programs out at Lakeside Hospital. And so it's new. It's new for our culture. We do act surgical. So we have a lot of these men and women here have been at Lakeside Hospital doing great. What are some key steps? Dr. Gupta is in the room. We're having orthopedic and ENT. What are some key steps that as a CMO, as the administration, I can do to help set us up for success? What are some key things you see? Because again, I have a whole group of a multidisciplinary team, as well as independent physicians, employed physicians that have not worked with learners to a great extent.
So I'm going to ask you just some specific technical questions, which will probably make sense to you, but maybe not everybody in the room. Have you already tripped the wire? Have you already started sending senior residents rotating, or have you
So we have our surgical residents do round out at Lakeside, but this will be
New de
new,
novo.
fresh.
The surgical residents, how long have they been rounding at Lakeside?
Oh, at least 10 years, I think. Haven't we been out there 10 years? Yeah.
General surgery rotations on Lakeside.
Yeah.
Okay, so that's your primary part right now. So we have a regional hospital that up until July of last year did not have a single resident in it. And so I'll kind of tell you how we approach this. The exact same thing. And we're starting in primary care, internal medicine, 8 residents per year. It'll be starting July 2026. We were just saying very similar timeline to, I think, either anesthesia or ortho, and a transitional year program. And that will be a very different group of residents than we have at Vanderbilt Central, because recruiting to, it's in, I have to make sure I say this right, Lebanon, Tennessee, as opposed to Lebanon, Tennessee. It's Lebanon, Tennessee. And it's just gonna be very different, but it's a hospital that people are there largely because they weren't planning on working with residents, and that was the whole point of being there. So some of it is acculturation, and I think that having really positive experiences. So I'd say you've already started that, because I'm guessing if you've had surgical residents that long, it is a very positive experience working with the surgical residents there. And so really anchoring on that and reminding the staff of that. And then as they're coming in as junior residents, is a little bit of a different flavor when you start as junior residents, but creating a sense of pride of this is why we're doing it. And then also just the simple business structure of it, of knowing that people stay where they train. And you are building the physician workforce. And so if you can get the staff to invest in that, once they have seen people stay on staff, it all goes away, because they recognize that this is actually how they build, and and they remember this person as a resident, and they feel like they grew them and they're part of it. But I think trying to initiate that. But I feel like if you've got the surgical residents there, that's already a positive aspect, because people are working with residents and then coming in. And then all the programs that I've heard that you're starting, really high caliber groups coming in. So I think it's going to be positive. But then it's the change. Change is a fear of loss, right? And what do they lose? But what do they gain? And so reminding them of what they gain with all of that. The way we did in the regional structures is we did not put any GME trainees out there until we felt that the quality of the hospital was very similar. So Vanderbilt acquired some hospitals. We waited until we felt like the quality was good. I mean, it was good before, but we felt like it was even better, and the access was better, and the patient population was coming up and things like that. And then what I did is in July of 2025, we purposely now we were tripping a CMS wire, so we had to be very careful with it, which sounds like you've already tripped, but we sent OB-GYN, ophthalmology, and emergency medicine, but we sent senior residents. And so the first experience of the staff who'd never worked with residents before were with senior residents. And then when we heard all the positive experiences, and then we were sending a few more senior residents this year. So this year we'll have other FTEs, and then July 2026. And then we're doing an entire community outreach, which is with staff, which is with people in the area, program directors in place, dinners, the whole shebang, just to really try to have the positive vibe with it. And these are all the positive things.
Thank you.
Yeah, that's exciting.
Since we are approaching the very end of the academic year, and everyone over on this side of the room, I don't know that there's any chiefs left anymore, Schwabi left, is going to move up and take on some new roles. Do you have any advice, particularly as the senior residents become more senior, on transitioning from really being a learner to being a leader of a team and leader of their junior residents?
Yeah, I mean, one thing, that 360 valve for me was so formative that, I don't know if I'm sure Christina continued this when you were 4 and a 5, but between the 4 and the 5 year, I took the 4 questions that were most hurtful to me on that 360 eval, and we did it for all of our senior residents. And we had them pick out the nurse practitioners and attendings that they wanted to send it to, and we sent it to the residents, all the junior residents. And it was really, all the questions were focused on, what does this person do really well? What that you wish they did more of? What does this person not do as well that you wish they did less of? What are this person's strengths and what are these person's weaknesses? And as a leader, and specifically focusing as a leader, and then gave them that feedback in their last eval right before they're going into their chief year and thinking about that. you know, the beauty of the academic year is you get to reset emotionally every year, and you have something to look forward to, and you get to say, okay, how? So for individuals, I would say this is the time to sit down, and when you're sitting down for your eval, you know, with your program director every 6 months, but really saying, what are my SMART goals? What am I trying to accomplish? What do I want to do differently? Where do I need to extend myself? What are my weaknesses? It's a great time to actually get feedback, because I'm guessing you have a pretty good idea of where people need to improve. So it's a good time to get that really assessment feedback of, this is my weakness. This is where I really want to work on that. So always being reflective, I think, is the most important, but it's a great time to be reflective as we're coming through the end of the year. And then also setting expectations. So this is part about delivering feedback. As you're becoming a more senior resident, you're going to have more junior residents coming in that you're responsible for. And the best way to get feedback is that preemptive way that we started earlier, is just setting your expectations and saying, okay, here's my team, here's how I'm going to run it. This is what my expectations are of the people who are around me. And then the feedback that you would give is when those expectations are not, you know, met or could be expanded, and then they expand throughout the year.
Anyone else in the audience have questions?
Or anyone on Zoom.
Or Zoom too? Yeah, Zoom land.
I'll try and speak loudly. As a DIO who's transitioned from being a PD, what are you doing to help all the PDs that you work with avoid burnout?
That's a great question. And I thought you were going to just stop with, what are you doing? I thought to myself, there's a sentence in there. What are you doing to help PDs avoid burnout? That is huge. I'll tell you, the first thing I do is every time the ACGME survey comes out, I send a letter to all the PDs to tell them not to take it personally. Right? Because I know that I didn't realize, even as a resident, and I don't think residents and fellows realize how personally program directors feel about their program. But in terms of burnout, one is creating a team around you that is able to support you and give you feedback, quite frankly, because it saves you from a lot of things, or people that you can bounce ideas off, and you don't have a structure. So vice chair, calling your vice chair, who happens to also be former program director, having people that you can call on for advice. And as you all are starting your new programs, you're going to, you know, be running into the exact same things and calling each other. How do you do that? And I think, but those are similar things that I do as DIO. There are things that I need to vent about, or things that I have questions about. And the parts that give me kind of resilience is being able to call someone else and saying, hey, am I on the right track? Am I doing this? And then I think also, you know, as long as the biggest part is the chair, is having leadership support for the program director. And, you know, I already see that here. I sense that. But having leadership support for the program directors is probably the biggest thing you can have for wellness, because even if you're struggling with what's going on in the program, if you feel like your leadership is supporting you and feels like you're doing a good job, and then you're going to be fine. And you're also going to be able to tackle those things. But if the residents are doing great and you don't feel like you have leadership support, that's not great. So I think, you know, having support and working through all those, and then making sure that leaders are supporting program directors is really important. Burnout, I mean, program director on average is now 3 to 5 years, which is very short and is not what we want. It's not what the ACGME wants. And you really want it to be the cycle of a resident. And actually, you know, I was in the position 5 years. However, the previous program director and I really made the transition probably about 2 years before that, but he really wanted to stay until he was 70. So we kept him in the role till he was 70. But that we really need to be able to extend that. The other thing for program directors are program director societies, right? APDS is a support group for surgeons. And so for those of you who are starting your program, being involved in the program director society for your group is huge, because that is the support group, and those are the people that you call on. And I regularly, a lot of program directors in surgery have now become DIOs, and we actually have a group of us, we call it ADIOS, which is Association of DIOs in Surgery. It's not really an association, but it's really just a text chain that is not a 501(c)(3), but we reach out and just ask, you know, have you had this happen? What do you do with this? You have to be very careful, because you're dealing with some things that really can get very sensitive, and so you want to make sure you're not identifying things. But having that support group is really important. thank you for asking, because not everybody thinks about program directors and their wellness.
Any advice for a surgery program director at a community-based surgery program that may not have the same alignments as academic medical centers have?
That is a great question. And I don't know, it's interesting because HCA, which is largely a bunch of community, they have their own program director society. Like they have sort of created that. But when you are at a standalone, independent, or if you're at a smaller group that's part of a consortium, I think it's really important to find, if you don't have the structure and the support internally where you are, finding people who are doing something similar to you. Because the issues that you're running into, I guarantee you, would be very similar to the issues that someone at a similarly sized hospital dealing with similar things. And so whether that is a group within the region, we have had, when I was program director, we would meet with we would meet virtually because there's so many tools now with the program directors in Tennessee. And then sometimes it extended to the program directors in the Southeast. And so I think one part would be finding a group of people who are dealing with the similar issues, because quite frankly, no one is going to understand more than someone who's in the exact same situation. So creating that community, even though it's not directly there, because it also gives you ideas of, well, this is how my administrator heard this when I was able to present that to them as this is the issue. And so it gives you ideas of how to approach things locally while having a strong support group there. So that would be my main suggestion. But I'd be happy to expand on that or think about that further if we want to talk about that, after this.
Any residents have any questions? Just gonna pick on you guys.
This is not necessarily to do with feedback, but more with the idea that, EPAs and simple may allow people to graduate early versus late. How is that going to affect fellowship applications and the timing of that?
Yeah. So believe it or not, sometimes fellowships start off cycle now already. You just don't see it. It's not normalized yet, but it happens. I mean, we have so many fellowships. It's every year we have people who extend their residencies because of life situations, and we will contact fellowship directors and they will start their fellowship late. So it already happens. But where the groups that have to get together on that are administrators and program directors, and that's not a big ask. Starting things off cycle is not a huge ask. The only thing that it makes it hard on is GME offices, because it's very nice to just orient everybody all at once with like 200 or 300 people, quite frankly. But the truth is when do people start working in hospitals? 365 days of the year. Every day we bring people in, you orient them. We've already figured that out for employment. That's the way the rest of the world works. And there's no reason that residency and fellowship can't adjust to that. It will be, it's like, well, the answer would be, well, we've always done it this way, right? Which you find is not always a good answer for progress. And so having something off cycle is not going to be the end of the world. It's going to be a little bit tougher in larger programs where you have and I don't know if you've seen it here, but we've seen it where we have people who will repeat or will be delayed 6 months and they're already off cycle with residency. So we can make it work. But good question, because it is different from what we've experienced before.
I just feel like the NRMP is a nasty society that doesn't want to change.
Well, the NRMP is the NRMP is already off cycle for their matches and things like that, but that doesn't dictate when you start. So you just you're just with it. And then the NRMP working for medical schools will probably still graduate, in the spring. So the main match would be disrupted for that. So my conflict there that I would just say right now is I used to be on the board of the NRMP. No, but I'll try to give you some feedback. So I'll try to give you an alternative way of thinking about things. Imagine that when people talk about the match being bad or whatever, what it was before. NRP started in 1953. And it started because medical students, what was it before then? It was me calling you and saying, hey, I've got a job at Vanderbilt. I'm only going to pay you $30,000. And you got 3 days to decide. Do you want it or not? Because it's gone in 3 days.
Yeah.
And even SOAP, which used to be the scramble, was a nightmare. And that was even after the match. So there are some good things with it. Now, there are also some things that need to be changed, but those are probably not at the NRP level. They're actually probably at the graduate medical education level in terms of thinking about pay and thinking about cycling and thinking about, different things like that. but all of those things workable. So, and I don't just like the way you're thinking. I think you're saying, well, what about this and what about that? But just like, I'd say like maybe expand that and say, okay, well, what would you need to do to have this happen?
Yeah.
So good thoughts.
Okay, I think we're gonna wrap up.
Dr. Terhune, it's been a pleasure and an honor to have you here with us. We can't ask for a better speaker, a distinguished lecture speaker, to
You're gonna have
educate us
something-
about feedback, and we'll definitely invite you back again.